Okay, thank you for joining us this evening. A very warm welcome to our webinar from Benenden Hospital this evening. My name's Phil. I'll be your host for this session, and I'm joined by our expert speaker, Mr. Simon Bailey, Consultant General Surgeon here at Benenden, who will be discussing hernia repair treatment. Well, for those of you who haven't joined one of these webinars before, the format is as follows. Mr. Bailey's presentation will last around 25 minutes, and this will be followed by a Q&A session where there's an opportunity for you to submit your questions, and you can do so by clicking the Q&A icon at the bottom of your screen. So you can submit your questions either during the presentation or following the presentation, and you can give your name when you submit your question, or you can do so anonymously. But at this point, we should let you know that if you do give your name, we are recording this session for archiving. If you'd like to book following this, we'll provide you with contact details at the end of the session. So without further delay, I will hand over to our expert, Mr. Simon Bailey.
Thank you, Phil, very much indeed. And good evening, everyone. Thank you firstly to Phil and Oliver and the team at Benenden for organising the technicalities of this evening and for preparing all of the slides. And thank you to everybody who is joining us. I see at present there are 43 on what I hope for you is a beautiful sunny evening. So Phil says I'll talk for 25 minutes on hernias. I could talk all day, but I'll try and keep it as short and pithy as possible for you. And give you as much opportunity to ask whatever questions you may have. So, Phil, could I have the next slide? So I won't bore you with too much detail. Suffice it to say, I've been a consultant general colorectal and keyhole laparoscopic surgeon for the last 20 years in the southeast of England in Kent. And I practice at Benenden Hospital. Should you require any more information about me, it's freely available on my website. So I won't bore you with the intricacies of that. I'll move along to the main meat of the evening. If I could have the next slide, please. So essentially, hernias and hernia repair is a very common condition, and I'll endeavour to give you an overview on what is quite a complex scenario and talk through the commoner types of hernias, which most people will see at some point potentially. We'll talk briefly about the causes, but most importantly about the symptoms and the way in which it's diagnosed. And then we'll talk about what is involved during the consultation period and potential assessment. But most importantly, and I'm sure what everybody is waiting to talk about this evening, is really what are the options for treatment? What are the latest developments in the options for treatment? And what are the outcomes and results? And finally, Phil will show you a patient case study, and then we'll leave plenty of opportunity for you to ask any questions that you may have. So Phil, next slide, if I may, please. So essentially, what is a hernia and what types of hernia can there be? Well, essentially, a hernia is a defect in the muscle wall, usually of the abdominal wall, but can occur internally, which allows the content of the abdomen, usually either a piece of fatty tissue called the omentum or the bowel, to protrude through it, giving a lump. On the screen that you can see in front of you are the commonest types of hernias. Epigastric, which is usually just above the belly button, just below the rib cage in the midline. An umbilical hernia, which is around the belly button itself. And a femoral hernia, which can occur in the groin, but deep in the groin, below what is indicated there, the inguinal ligament. The commonest type of hernia, however, by far is an inguinal hernia, and predominantly more men than women suffer from it, but it's becoming increasingly common in women. So if you move on to the next slide, Phil, why are hernias potential issue? Well, to firstly and most importantly reassure everybody, what you can see on the screen at the present moment with regard to incarceration and or strangulation is actually a very rare event and not something that we see terribly often, I'm delighted to say. Incarceration occurs when a bit of the bowel protrudes through the hernia, as you can see on the left-hand side of the screen, and gets caught within the hernia. These types of hernias make it difficult to push the content back in again and can be quite tender, particularly after exercise. On the right hand side, you can see that the bowel has changed colour, and that's because this is a strangulated hernia where the blood supply to that affected piece of bowel is compromised, causing it initially to become devolved blood and eventually, if left long enough, to burst. Now, to reassure you, the risk of that happening is actually vanishingly small. If I fix 400 hernias a year, I fix 2 or 3 in anger, either on the left or the right hand side of the screen. But obviously, prevention is by far better than cure, hence the reason that we're keen to get at these things earlier rather than later. Next slide, please, if I may. So, as I said a moment ago, what is a hernia? Well, as you can see from the diagram, it is where a part of the intestinal fat, the omentum, pokes through a weakness. The commonest weaknesses around the belly button, as I've said before, or within the groin itself. If that window where the muscle is weakened suddenly contracts, then the bowel can get caught, resulting in incarceration. But I hasten to add that scenario is very unlikely, and so too is compromise to the blood supply, which would cause strangulation. As is quoted here, about 2 to 3 in every 100 of presentations of hernias strangulate in the first year. But if the hernia is there more chronically for many years, the risk of strangulation and incarceration gradually diminishes. Thank you. Next slide, please. So, what are the consequences of not treating a hernia? Well, essentially, initially, the main consequence is the hernia may get larger. And as they increase in size, they may cause more and more discomfiture, reducing mobility and reducing the ability of someone to perform the task that they would want to do. If left for longer, then gut symptoms can occur. For example, if the transit through the gut is slowed down, some patients present with constipation. Groin hernias are particularly closely related to the bladder, and some patients find that they get symptoms of urgency and frequency to pass urine, which can be quite debilitating, particularly at night. Obviously, as I've already alluded to, if it becomes incarcerated or strangulated, then pain may pursue, and in the worst case scenario, abdominal distension, nausea, and vomiting. But this presentation is very rare. Essentially, the critical thing is that if a hernia is sore and it's reducing your ability to do the normal things that you would want to do, that's the time to start considering having it corrected. Next one, please. So, what are the commonest causes of hernia? Well, the vast majority are caused by sudden changes in the pressure of the abdominal cavity and sudden tension applied because of that on the anterior abdominal wall muscle. We've seen an awful lot of hernias recently following the COVID pandemic, where patients are presented with very bad and chronic coughs, and that actually is generally the commonest cause. It can be as innocuous an injury as stretching up for a high shelf to a sudden sneeze or cough. But as we get older, so our gut gets slower, and constipation can certainly affect hernia formation. Long periods of sitting and straining, I'm afraid, are not good for us. At this time of year, people leaping out into the garden, having not done a great deal of exercise or lifting, is also a common reason. And of course, people who go to the gym or perform exercises which they're not used to can promulgate a hernia formation. It is not uncommon to find a family history of hernias, particularly on the male side of the family. And with hernias such as incisional hernias, where previous operations have occurred, then it is possible for the repair after the primary operation to fail and for hernias to occur. We have here on the slide connective tissue disorders and other health conditions. These actually are generally very rare causes. The vast majority are created by sudden changes in abdominal pressure, as alluded to a moment ago. Next slide, please. Thank you. So, what are the symptoms? Well, the first and primary symptom is that patients often just notice the bulge itself. They may be showering one day and actually see that one side looks slightly larger than the other. Some patients find that they develop tenderness in and around the area as a first presenting symptom, and that can be associated with or without a lump. It doesn't necessarily mean that you'll be able to feel the lump yourself. It may be that pain and discomforture, particularly in the groin, is the first symptom. The bulge can often be increased in size by increasing abdominal pressure, for example, when coughing or lifting something heavy. But when you lie down flat and gently massage it, the bulge may go back in again. If a little bit of small bowel is caught within that bulge, then it may be associated with a squelch, which is not an uncommon finding. Some patients purely and simply get pain on exercise and think that they've got a problem with their hip or their knee or so forth, and often present to orthopedic surgeons when in fact they have very small hernias that they can't feel. The sensation of burning that's alluded to in the third paragraph is uncommon. Very occasionally there are some complex nerves that run particularly in the groin, and if they are pressed upon by a small lump, it can cause a sensation of warm water being poured over the inside of the groin, or pain into the testicle or the vagina. But again, that's generally uncommon. And finally, swelling of the scrotum or sensation of heaviness in the scrotum is usually associated with a long-standing and very large chronic hernia, and has usually been predated by the symptoms that I've discussed previously. Next slide, please. So I think that's a critical thing to say. Everybody who presents with a hernia does so in a different manner. For the thousands of people I've seen with hernias, I've seen and heard thousands of different stories. So you might have the swelling. It might be a soft squidgy lump in the groin that you can push back with that aforementioned squelch sign. Sometimes the hernias appear and you lie down or sit down and they've gone. Pain is not always a symptom, and some people have completely asymptomatic large hernias, and other people have very small, impalpable hernias, which cause a great deal of discomfiture. And occasionally, you might pop to see your GP or family doctor for some completely other reason, and they'll say, "Oh, have you noticed that you've got a hernia there?" Again, that's nothing to worry about, and it may be that you've actually had the hernia for some considerable period of time. But if there is a diagnostic concern or there is an issue, then simply organising a scan is very straightforward and very easy to do, and your GP would be able to do that for you. Next slide, please, Phil. So, how is a hernia diagnosed? 90% of the diagnosis is made by simply listening to what the patient has to tell you. You know if there is a change in your body, and you know if you've noticed something different. When you come to the outpatient clinic, having taken a history and listened to the story, it's absolutely essential that the surgeon you go to see physically examines the area properly. This should be done in both the lying and standing position, and the examining surgeon should make certain that they ask you to cough, sneeze, or move in the way that produces your symptom profile. If there is a diagnostic issue with it and it's not immediately obvious clinically, then there are a number of ways in which we can investigate a hernia more accurately. This can either be done with a dynamic ultrasound scan, again in the lying and standing position, and again by applying abdominal pressure, which can allow us to actually visualize the defect in real time. In very, very rare circumstances where there remains an issue, then these days with modern 3T MRI scanners, which we have at Benenden, it is possible to MRI the affected area and actually during the acquisition of the pictures get the patient to cough so that this demonstrates whether or not there is in fact a hernia. 99.9% of the time, however, the diagnosis is simply made by the patient and by physical examination. Next slide, please, Phil. So, what are the treatment options? The first and most important thing to say is that, and I say this very regularly, if you ever meet a surgeon who tells you you have to have an operation, if it's not life-saving, run away from them. Essentially, the critical question that one has to answer is how much does this affect the quality of your day-to-day life? If the answer to that question is not greatly, and simple occasional over-the-counter medication such as paracetamol or ibuprofen is able to control your symptom and you haven't had any worrying issues from it, regards incarceration or strangulation, then a period of watchful waiting and observation is perfectly fair enough. However, I'm here this evening obviously to talk about surgery, so with the next slide we will discuss that. So there are a myriad of different ways of correcting hernias, and it really depends upon the anatomical location, the surgeon's abilities, and the patient's preference, the latter being the most important. Essentially, hernia repair can be divided into open or laparoscopic keyhole repairs, and then the question one has to ask is whether mesh or no mesh is required in order to do so. The commonest method of hernia repair worldwide is open hernia repair, and for the hernia that's indicated on this particular slide, it would be an inguinal hernia. The commonest technique that's used again in the UK and worldwide is the Liechtenstein meshed inguinal hernia repair. This essentially involves a small incision in the groin. 8 to 10 centimeters is a little bit larger than normal, and then the anatomy is exposed. Initially, the hernia and its content are reduced back into the abdominal cavity. The musculature is then reopposed in an anatomical fashion using stitches which either dissolve over a period of time or remain in place, dependent on the surgeon's preference and the anatomy itself. And then a piece of mesh is placed which essentially covers the defect and reinforces the repair to minimize the risk of recurrence. These type of operations can be done both under general anesthetic, where you're completely asleep, local anesthetic, where just the area of worry, the area of surgery is infiltrated or numbed using local anesthetic. This technique is generally reserved for those patients who are not fit for any other form of anesthetic. And then the halfway house is a spinal anesthetic, where a local anesthetic is injected into the back that numbs the legs and the groin for approximately 3 to 4 hours, allowing time for surgery and recovery. But you are awake when this occurs. Open hernia repair is generally applied for the femoral, inguinal, umbilical, epigastric hernias and the larger incisional hernias. Thanks, Phil. Next slide, please. As I said, the decision when the surgeon offers surgery is whether or not it can be done by keyhole. Keyhole surgical interventions are generally reserved for groin hernias, particularly inguinal hernias, but certain types of incisional hernias and other rarer abdominal hernias, such as the Spigelian hernia, are also corrected by the keyhole technique. The operative surgeon generally makes smaller incisions, usually approximately 3 of them, with cuts which are about 1 centimetre to 2 apart. One of the ports which is placed will have a camera to allow visualization of the area, and also for carbon dioxide to be blown in, which opens up the space to allow the operation to occur. 2 further ports essentially hold the instruments that are then used to firstly reduce the hernia and put it back where it's supposed to be, and then put in a piece of mesh which acts rather like the repair of a hull of a boat, where the mesh is held in position by the pressure of the abdominal cavity. Some surgeons tack them in place, although this is not being used as frequently any longer, as glue is much more commonly used, meaning that there's no foreign material after a period of time when the glue is reabsorbed. Keyhole surgery is generally reserved for smaller hernias, or those hernias which occur simultaneously on both sides. We call that bilateral hernia repair. The recovery from both keyhole surgical interventions and open interventions is generally the same. And if one looks at quality of life studies at 30 days, those who've had keyhole operations and those who have open operations score very similarly. Although initially, recovery in the first week after keyhole surgery is slightly quicker. The final thing I will say is that keyhole operations, laparoscopic hernia repairs, are always done under a general anaesthetic, so you are completely asleep. Next slide, please. So what would one expect after an operation? Well, the vast majority of hernia repairs are performed as day surgical interventions. Come into the hospital early in the morning, when you will be seen and admitted by the admitting nursing staff on the ward. You will then see the anaesthetist and the consultant to discuss both the anaesthetic and any further questions that you may have for the surgeon themselves, and your consent form would need then to be countersigned. Following the surgery, providing you are comfortable and confident and have passed urine, then it is safe for you to go home after being reviewed by the anaesthetist, the surgeon, and the nursing staff looking after you. Generally speaking, in the first 1 to 5 days, the first week following surgery, most people are able to walk around their house, generally get outside and walk very short distances. Most people simply require simple pain relief, such as paracetamol and ibuprofen regularly, but stronger painkillers are dispensed on discharge from the hospital, just in case more is required. Stitches usually dissolve under the skin, and there is waterproof dressing applied over the top of the wounds, so patients are able to shower but not bath. Generally speaking, after a week of taking it reasonably easily, it's then possible to gradually build your exercise tolerance, essentially dependent on how comfortable and confident you feel. It is critical, however, that picking up anything over 5 kilos is avoided at least until the 3-week mark. So, for example, I generally say to people, a small bag of shopping is fine, and picking a light toddler up, provided you use good manual handling technique, is okay. But anything heavier than that should be avoided, as the repair is still fairly immature at this point, and it is the commonest time when rupture and issues can occur. As far as driving is concerned, generally speaking, 10 days to 2 weeks is required, more for an insurer than anything else, but most people are back driving within a couple of weeks. And within 3 weeks, most people are off pain relief and is back to at least 75% of normal activity. Generally speaking, hernia repairs are fully sound at 6 weeks, and at this point, the vast majority of patients are able to go back to their normal day-to-day activities and normal exercise regimes. The one caveat that I do put in that is that professional sports people or people who play higher level of sport generally take a little longer to recover back to their normal functional capacity. but that's not most of us. Next slide, please, Phil. So I'd now like to show you, the team at Benenden would like to show you a short synopsis of a gentleman called Terry King and his successful hernia repair. Over to you, Phil.
I was experiencing some pain and discomfort in the lower stomach area. I quickly had appointments to see, make sure that the diagnosis was correct, which he confirmed, and he set out the procedures, how it would roll out for me. The operation was carried out in August, having only received diagnosis in early summer, so that was marvellous. The nursing care was first class, and a little bit being like being in a hotel, being on holiday. Your every need was pampered to, and you're made very comfortable and at home. I think after about a month I was back playing golf and not feeling any ill effects. Yes, the highlight of my experience at Benenden Hospital was the seamlessly smooth transition from operating theatre to my private room, where I enjoyed a light snack in the knowledge that everything had gone fine and I had the rest of my life to look forward to, unhindered by having waiting list issues hanging over me.
Thank you, Phil, for that. I'm cognizant of the time. It's now 7:30. So I was wondering, do you want to throw the floor open to the questions, Phil?
Yeah, of course. Thank you for that informative presentation, Mr. Bailey. Lots of useful information to digest there. So we can take some questions from the attendees. First of which is a person asking, can a hernia with a bulge cause lower backache?
So the answer to that question is it's uncommon to do so. If a hernia is causing a change in the way in which someone is, their posture and so forth, it can certainly affect the lower back. The nerves that run through the inguinal canal generally are peripheral nerves, i.e. they don't come from the lumbar back region, and common nerve pain or aches are within the testicle, the groin, or down the front of the leg. So I think that unlikely is the honest answer to that question.
Okay, thank you. The next person asks, you mentioned that it is bad to leave a hernia. Does that apply to all types of hernia? Would a very minor one ever go away on its own?
So the answer to the question is, if a hernia is present, it won't go of its own accord. You can't exercise to get rid of it. However, go back to my original premise. If you ever meet a surgeon who says to you, you've got to have an operation, run away from them. Essentially, if it's asymptomatic and it's not preventing any normal day-to-day activity and it's small and long-standing, particularly if it's in the upper part of the abdominal cavity, the likelihood of it progressing and causing a problem is actually quite small. So I would strongly counsel a patient in that circumstance that a watchful waiting policy is the one to go for.
Okay, thank you. This attendee asks, if I had an open hernia repair under local anaesthetic, Would I need to stay overnight? I'm very anxious of general anaesthetic and hospital stays.
No, not in the slightest. Day case operation without any issue whatsoever. The local anaesthetic, as I said, could either be instilled around the groin itself, which we do very uncommonly these days in less than 5% of patients, but a spinal anaesthetic, which wears off after 2 or 3 hours, is extremely safe, extremely effective, and would not necessitate an inpatient stay.
Okay, thank you, Mr. Bailey. The next attendee, Mr. Tarleton, says, I developed an incisional hernia after keyhole surgery on my bowel. I've since experienced constipation and discomfort. Is this dangerous?
Okay, well, I'm very sorry to hear that you've developed an incisional hernia. Constipation is a very common condition. The worrying symptoms to watch out for from hernias are if the constipation becomes very severe, associated with a lack of passing flatus, abdominal distension, nausea, and vomiting. That is an indication of incarceration and impending problem and should be checked quickly. The good news is that if the incisional hernia is larger in size, the potential for this occurring is actually very small. But if the gentleman is experiencing symptoms from it, then it would most definitely be sensible for him to have that checked sooner rather than later.
Okay, thank you. This person asks, I have a hiatus hernia. How would you treat this?
Right. Now, a hiatus hernia is a completely different kettle of fish. Essentially, hiatus hernias are incredibly common conditions. About 95% of us have them to a greater or lesser extent. They cause symptoms of gastroesophageal reflux, heartburn, discomfiture under the breastbone, burning sensation on swallowing, and so forth. Most hiatus hernias are treated by lifestyle modification, avoidance of precipitants such as spicy food, alcohol, cigarette smoking, tobacco chewing, and simple anti-acid medications. If these these factors don't work, then investigation of the hiatus hernia is important, and that's done by a camera test to look down through the gullet and into the stomach to assess the size and type of the hernia. And it's also then possible to determine how much acidity is generated for what sort of frequency and what sort of height. And this is done with either something called pH and manometry studies or a Bravo capsule. Repair of the hiatus hernia, there are a multiplicity of different types, and that's actually a very specialist circumstance which I can do, but we don't do at Benenden.
Okay, thank you. This next attendee says, would a mesh-free repair for an indirect bilateral inguinal hernia be advisable?
Yes, well, so the answer to that question is it is always patient choice. The Scholdice and Bassini repairs were the original way that we performed hernia surgery for inguinal or groin hernias prior to the invention of mesh. The difficulty is that younger surgeons have not been trained in the original ways of doing it and therefore don't know how to do it. I do Scholdice and Bassini repairs, and generally approximately 10% of patients who come to see me opt for that technique. It's a very good technique. The recurrence rates are slightly higher long term. With a mesh repair, the recurrence rate is stated at 1% at 10 years. With an anatomical repair, the recurrence rate is approximately 1 to 2% per annum. But generally speaking, if you get 5 years out from surgery, the risk of it coming back again is zero. So they are very good operations. They work extremely well, and they're certainly available to do.
This next attendee, Annabelle, asks, for an umbilical hernia, is the recurrence rate 30% as advised by an NHS consultant?
No. So very straightforward. The recurrence rate for an umbilical hernia should be less than 2 to 5% over a 5-year period. So I'm not entirely sure where that figure was obtained from.
This attendee asks, is having a cough during the first week after surgery going to be a problem?
Well, the answer to that question is yes, it will be quite sore, and you'll need to put your hand over the area afterwards and take your pain relief regularly. Obviously, significant and profound coughs generally would preclude doing a hernia repair until that cough is treated or investigated and treated. But, you know, the occasional cough and sneeze is not an issue at all.
Okay, thank you. This attendee asks, I have apologies if I'm pronouncing this incorrectly, Spigelian hernia, and I'm going to have a laparoscopic surgery at Benenden soon. Can I be driven back to London after the op?
Yes. You make sure you take plenty of pain relief, drive slowly and avoid emergency stops, but shouldn't be an issue at all to drive back to London.
Okay, bear with me. So the next attendee asks, how common is it to have very infrequent episodes, protrusion every 3 months or so?
That's difficult to say. I mean, it's most people, if they have a hernia, it's present on a regular basis, well, it's usually just there. So to have an episode every 3 months would be very unusual.
This is quite detailed, this one. I have a shunt which drains into my bowel. I'm also scheduled to have an umbilical repair soon. Is it advisable to go ahead with this, as I'm worried it may impact on the shunt into the bowel? My consultant is aware.
Right. Shunts, lots of different types of shunts. My thought might be that this is a ventriculoperitoneal shunt, which drains something called a hydrocephalus. This is really very esoteric. That will drain into the abdominal cavity, not into the bowel. And it's usually tunneled under the skin and sits in the pelvis. Um, the answer to your question is if you're having an umbilical hernia repair, it's unlikely that they'd go anywhere near it. And I'm sure the operative consultant will have done the appropriate imaging to know where the course of that drain is before embarking on surgery. If they haven't, I would certainly ask them to do so.
Okay, thank you. This next attendee, Russell, asks, I had a bilateral hernia repair 5 years ago, and one side has reoccurred. How difficult is it to have the repair carried out again, and what are the risks second time around?
Yeah, the good question. So, yes, it is certainly possible to have it repaired. It does slightly increase the complexity of the surgery, but not massively. It would need an open repair because the anatomy following a keyhole surgery is too distorted to get back into the same area to see the anatomy. Um, the risks, as far as risks of surgery are concerned, well, the risks of any operation, things like infection, bleeding, pain, delayed wound healing, and bruising are the risks of all surgery. The main risk of redo operations in a man is damage to the testicular vessels, causing the testicle to either atrophy or shrink, or in the worst case scenario, if one is unable to expose the anatomy properly, then removal of the testicle is required. The risk of damage to the testicle is of the order of 1 in 5 to 8,000, and the risk of having to remove a testicle is approximately 1 in 10 to 15,000. So I can say that in 30 years of fixing a hernia, I've never had to remove anybody's testicle, but it is a recognised complication, and therefore the patient should be well aware of that.
Thank you. The next person asks, with keyhole surgery for a bilateral inguinal hernia, do you perform TAPP or TEP?
Okay, so the question being asked is the TAP is a transabdominal pre-peritoneal repair, and a TEP is a totally extraperitoneal repair. That's quite fine print. I perform a TEP because I believe you can view the anatomy more accurately, and the mesh is not placed inside the abdominal cavity, so the chance of it migrating and causing issue is smaller.
Thank you. The next person asks, does the body tolerate a mesh hernia repair well?
Absolutely. There are about 10 million per annum done worldwide, with extraordinarily good and well documented outcomes. And the mesh itself is an inert entity. It is recognized by both the FDA in the United States and the National Institute of Clinical Health Excellence here in the UK. So yes, we wouldn't be using it if it wasn't tolerated well.
Thank you. The next question is, I had an incisional hernia about 6 months post-op, had hernia repair. Sutured as small and not keen on mesh. Now have another small bulge nearby. Uncomfortable sitting for long, but I'm not sure what to do. What do you advise?
So that needs a clinical assessment via the general practitioner in the first instance, and if there is any concern or quandary on the diagnosis, then imaging initially with ultrasound scan would be the sensible thing to do. That ought to be assessed.
This person asks, would a mesh-free repair for a bilateral inguinal hernia on a very active 65-year-old that weight trains and exercises a lot be advisable?
So the answer to that question, if one weight trains and exercises, there is an increased potential for recurrence. And therefore, yes, it is feasible, but one would potentially need to change the exercise regimen, which may well be the promulgating factor in the first instance. In that circumstance, I have operated on international powerlifters in the past, and every time have used mesh in that circumstance.
Thank you. The next person asks, how soon after heart surgery, aortic root replacement, would you be able to perform a hernia repair?
So with aortic root replacement, it is likely that the patient would need to be taking an antiplatelet blood thinning agent. They would want that in situ for at least 6 months. I would suggest that after that sort of surgery, 1A would need a higher level of anesthetic input, and secondarily, I would leave it at least 6 months, preferably a year following the primary index heart operation.
Thank you. Another fairly detailed question here from attendee Chris. I had an operation for an inguinal hernia 8 years ago. Following a recent ultrasound, I now have two small inguinal hernias left and right. Will there be a problem operating on the same place again when a mesh was put in 8 years ago, and would both sides be done at the same time? A recent physical exam showed there was no protrusion, so no need for an operation right now. My question is more about the future, as I anticipate a need at some point.
Okay, so again, I would only recommend surgery if it was symptomatic and affecting quality of life. Essentially, it's possible to do one or both sides at the same time. Is there a problem operating in the same place? No, not really. Scarring can distort the anatomy slightly, but any good and competent hernia surgeon should be able to negotiate their way around that without too much ado. Excuse me.
This person asks, why is laparoscopic inguinal hernia repair recovery time less than an open repair? I think they're saying.
Because well, that's a good question. So as I go back to my original fact, the quality of life studies at 30 days, really that there is no difference between the two. If you look at patient activity, pain levels, and satisfaction with outcome. Keyhole surgery generally is done through slightly smaller incisions, which generally tend not to be quite as painful in the first 2 to 5 days. But analgesia demand at a week is essentially the same in both groups, and most people don't require any surgery. So the benefits of laparoscopic surgery with regard to pain relief are generally in the first week, but negligible thereafter.
Thank you. This lady asks, I have a Spigelian, was
Yes.
it?
Yep, Spigelian, almost.
Spigelian hernia, and I've been given conflicting advice. My private consultant recommends open surgery, but the NHS consultant advises laparoscopic surgery and removal of my gallbladder at the same time. The waiting time for NHS is lengthy, whereas the private consultant can do the surgery next week. I'm concerned whether I'm having the optimal treatment. I have Parkinson's and arthritis.
That's an extremely difficult question, I'm afraid, to answer without seeing the patient properly, taking a full history, full physical examination, understanding what medications and investigations have been done, and so forth. I am certain that both consultants will have their reasons and rationales for doing that, and that, I'm afraid, is something that the patient would need to discuss directly with their both private and NHS consultants. But I would strongly recommend to them that the time factor really shouldn't be an issue. What should be the most important thing is doing it in the right and sensible manner. It's unusual to remove gallbladders at the same time as doing hernia surgery.
Thank you. And somebody asks, I have a supra-umbilical hernia, and I also have gallstones and kidney stones. Would that complicate my hernia operation?
No. As long as you're dealing with the inguinal hernia, the kidney stones, well, they're a subsidiary issue. They can be very painful and unpleasant, but if they're not causing any issue, leave them be. And the same thing with the gallstones.
Okay, thank you. Straightforward. If I'm on blood pressure tablets, 5 milligrams, would surgery be okay?
Absolutely no problem in the slightest. A small dose of antihypertensive agent is extraordinarily common in the population, and the anaesthetist and the pre-admission team would give advice on that without any problem whatsoever.
And this person asks, is the mesh cut to size?
Yes, absolutely. Each piece of mesh is individually tailored for the size and anatomy of the patient in order to cover the area appropriately, but not to put excessive tissue material in.
Thank you. And I think you answered this with your penultimate slide, Mr. Bailey, but it might be worth reiterating. This person asks, is there any limit on the weight within normal lifting capability that can be lifted after hernia repair?
So I tell everybody not to lift anything over 5 kilos for the first 3 weeks and 10 kilos for the first 6 weeks. And thereafter, generally, people can lift whatever they want in reason using good manual handling technique. By the 8-week point, most hernia repairs are 100% sound, but obviously one needs to always be careful and not overload the repair. Nothing is 100% guaranteed.
The final question here is, with a mesh-free repair on an inguinal indirect hernia, are you able to operate on any size hernia, or does it have to be small, 1 to 2 centimeters?
No, you can operate on any size hernia, but obviously with a very large hernia, the tissue is generally very much more attenuated and thinned, and therefore the success long term of repairing it with just an anatomical repair is lower. It's very difficult to quantify that, unfortunately, as numbers are small, but certainly the larger they are, the less long-term success there is with an anatomical repair alone.
Okay, I think we are at a point where we've answered all your questions. So I will move on to the final slide. As it says on the screen there, following this session, we are offering a callback from your dedicated patient advisor. You will also receive the recording of the session, some treatment information, pricing, and some reward points for our loyalty scheme via email. And obviously, as it says there on the screen, you can access hernia treatment via self-pay through your Benenden Health membership, your private medical insurer, or the NHS. And obviously, you can select your specific contact preferences, and then we can keep you updated on upcoming news and offers and events. And following this session, you'll receive a survey, and we'll be very grateful if you could complete that, because it helps to inform and shape our future events. If you would like to discuss your consultation, our private patient team are here. The lines are open tonight until 8:30, or weekdays 8 a.m. to 6 p.m. if you wanted to speak to the private patient team. And the contact number is on your screen there. Next month, we have a variety of webinar events on knee surgery, tummy tuck surgery, and shoulder pain treatment. So you can sign up to any of those and find more information on our website. All that remains for me to say is thank you very much on behalf of Mr. Bailey and the team here at Benenden Hospital. Thank you for tuning in, and we hope to hear from you very soon. Thank you and goodbye.
Thank you very much.